a phase 3 trial of Luspatercept in patients with transfusion-dependent β-Thalassemia. Definition: the β-Thalassemias are a group of inherited hemoglobin disorders that represent a substantial global health burden, defecting production of beta-globin change of adult hemoglobin causes an imbalanced ratio of alpha-globin to beta-globin. Patients with transfusion-dependent beta-thalassemia present in early childhood and need regular red cell transfusions to maintain adequate hemoglobin levels.
Thalassemia is an inherited blood disorder in which the body produces an abnormal form of hemoglobin or oxygen-carrying protein. Presence of faulty hemoglobin results in large-scale destruction of red blood cells, which leads to anemia. About 100,000 babies worldwide are born with severe forms of thalassemia each year. Thalassemia occurs most frequently in people of Italian, Greek, Middle Eastern, Southern Asian, and African ancestry. Hemoglobin consists of two different proteins, an alpha and a beta. If the body doesn't produce enough of either of these two proteins, the red blood cells do not form properly and cannot carry sufficient oxygen. The result is anemia that begins in early childhood and lasts throughout life. This disorder can be classified into two types, alpha thalassemia and beta thalassemia. The severity depends on how many of the 4 genes for alpha globin or 2 genes for beta globin are missing. It is estimated that 1.5% of the global population carries genes of beta-thalassemia. Thalassemia is caused due to particular genetic defects which are inheritable. Alpha-thalassemia results due to mutation in the genes HBA and HBA2. Beta-thalassemia is due to mutations in the HBB gene on chromosome 11. Symptoms depend on the type of thalassemia and can vary from mild to severe. Anemia can cause pale skin, fatigue, weakness, and shortness of breath. Patients may also suffer with an enlarged spleen, jaundice, dark color of urine, and loss of appetite. Thalassemia patients can get an overload of iron in their bodies, which can lead to damage of the heart, liver, and endocrine system. Children can suffer with slow physical growth and delayed puberty. Abnormal heart rhythms and congestive heart failure may be associated with severe thalassemia. If adequate iron chelation therapy is not provided, almost all patients accumulate potentially fatal iron levels. Diagnosis of thalassemia is typically made by blood tests, including a complete blood count, hemoglobin electrophoresis test, and genetic analysis. Prenatal diagnosis of thalassemia is best carried out by chorionic villus sampling in the first trimester of pregnancy. Treatment of thalassemia depends on the type and severity. Treatment for the severe form of disease often includes regular blood transfusions, iron chelation therapy, a process by which excess iron from the body, and supplementation of folic acid. Bone marrow transplantation may be used to cure the condition, especially in young people who have a human leukocyte antigen matched donor. Success rates in bone marrow transplantation have been in the 80 to 90% range. For more information about list of expert doctors, hospitals, and ongoing clinical trials, please visit www.expertdocs.com.
Application in medicine. Luspatercept, a recombinant fusion protein that binds to select transforming growth factor beta superfamily ligands, may enhance erythroid maturation and reduce the transfusion burden, the total number of red cell units transfused in such patients. Patients with transfusion-dependent beta-thalassemia need regular red cell transfusions.
Erythropoiesis, the process of making red blood cells from hematopoietic stem cells, is regulated by a number of secreted growth factors. The cytokine hormone erythropoietin promotes proliferation, differentiation, and survival of early-stage erythroid progenitors. In late stages, TGF-beta superfamily ligands, such as GDF11, act as negative regulators of red blood cell differentiation. GDF11 signaling through the activin type 2B receptor activates the SMAD2/3 signaling pathway. In the nucleus, the activated SMAD complex binds to DNA to modulate gene transcription. Luspatercept is an investigational fusion protein consisting of the modified extracellular domain of the activin type 2b receptor linked to the Fc domain of human immunoglobulin G1. In preclinical models, luspatercept acts as a ligand trap by binding free TGF-beta superfamily ligands such as GDF11. This may block interaction of the GDF11 ligand with activin type 2b receptors and thus reduce SMAD2/3 signaling. In this manner, luspatercept is hypothesized to restore late-stage erythropoiesis via a mechanism distinct from that of erythropoietin by reducing the inhibitory effects of signaling through TGF-beta superfamily ligands, such as GDF11. In vivo, luspatercept treatment leads to increases in red blood cells as well as increased hemoglobin levels and hematocrit. Luspatercept is being investigated for the treatment of anemias with ineffective erythropoiesis in patients with MDS or β-Thalassemia.
Pros and cons. Pros: reduction in the transfusion burden of a less 33% and a less 15% from treatment baseline. These available therapies have resulted in improved prognosis and longer survival. Cons: the median longest duration of response with luspatercept was 104 days or 98 days. Luspatercept was associated with increased incidence of bone pain, arthralgia, dizziness, hypertension, and hyperuricemia, persistence of high morbidity and mortality.
The study is the multi-center, randomized placebo-controlled RCT trial, and we perform this in 336 transfusion-dependent thalassemia patients from 65 sites from 17 countries around the world. And, country including Italy, Greece, US, UK, go to the Middle East such as the Lebanon, and to the Far East such as Thailand, Malaysia. So this is one of the biggest thalassemia studies so far. The primary outcome of this trial in this belief study is just to see whether with the use of luspatercept, which is the subcutaneous injection, will help to reduce over 33% of the transfusion requirement in this particular patient group, comparing between the 12 weeks of the run-in period that we use as a control in order to measure the number of the transfusion that the patient requires. And that's the primary outcome that we see the clinical response of transfusion reduction over 33% at the week 13 to week 24. And the secondary objective is just to look at the transfusion reduction can go even a bit further to over 50%, at the same period of evaluation. And the study has reached both, a major primary outcome. And in the presentation that I'm doing for this year ASH, it's just to further evaluate, those who respond quite well to the molecule to see whether, this response is sustainable beyond 24 weeks. And the result that we are showing that it seems to be the case, because we can see, those who respond quite well, they continue to respond even after 24 weeks. And we see the response up to 54 weeks based on, our evaluation based latest data lock in September.
You should apply in Ecuador. It is necessary to know these treatments to be able to implement them in Ecuador to improve the quality of life of the patient with transfusion-dependent β-Thalassemia.
I have presented the data concerning the French trials for beta-thalassemia patient and the sickle cell anemic patient. In particular, the trial is sponsored in France by Bluebird Bio, with whom we collaborate since 2002. And we recently treated two beta-E, beta-0 patient, and they are both transfusion-independent since the first month after transplantation. Conversely, we only treated recently the first patient with the sickle cell anemia, and the follow-up of this patient is too short to share with you any encouraging information. The follow-up of the first two patients are 12 months for the first one and 6 months for the second one. The production of the therapeutical hemoglobin is very stable over the time, and they do not need any other treatment except the iron chelation.
Conclusion. To sum up, Luspatercept was associated with mainly low-grade adverse events, although the percentage of patients who had thromboembolic events appeared to be somewhat increased.
Other than chelation, there are several new different approaches to treat thalassemia. The bone marrow transplantation was implemented already years ago, so I'm not going to talk about that. There is a possibility of modulate the imbalance of alpha and beta chain, which is the hallmark of the pathophysiology of thalassemia. And this can be achieved inducing fetal hemoglobin or correcting the ineffective erythropoiesis. And to do that, there are clinical trials on fetal hemoglobin inducer, pharmacologically, or even through genome editing, gene editing. So trying to increase the production of fetal hemoglobin, correcting a molecular regulation of hemoglobin synthesis. The other possibility is to correct or reduce ineffective erythropoiesis, and for this purpose there are clinical trials ongoing with a molecule which is a ACE inhibitor trap, the Luspatercept and sotatercept molecules. They are on clinical trials. We will see the results soon, and that's promising. Last, gene therapy. Gene therapy was a dream for thalassemia, now it's becoming a reality. And recently, 1 month ago, a paper has been published in New England Journal of Medicine presenting the first body of results with gene therapy. I think that we still have a long way to go, but for sure the future is very promising.
For this reason, if we decide to administer this treatment to our patient, we must have rigorous control to avoid complications. Thank you.